Okay, welcome back. I'm now going to the adrenal glands. So mainly we are going to be talking about Addisons and Cushing's, which are your two main things that you will see and that may be on boards. Plus we'll talk about another disorder known as pheochromocytoma and CAH, congenital adrenal hyperplasia. So those are going to be the main disorders that we're going to concentrate on. So very exciting. So let's start our new adventure of the adrenal glands. All right, this is in the form of a fast fact sheet, and we are going to be discussing in your med search book, page 1402 through 1411 in your PEDS book 998 through 992. So when we think about the adrenal glands, well, the adrenal glands are what we call suprarenal glands, supra meaning on top of, so they lay on top of or attached to the upper portion of the kidneys. Now, we know that they are highly vascular, so if you have a disturbance over there, they will bleed easily. There are two main divisions. There's the outer layer, which is the adrenal cortex, and the adrenal cortex is made up of 90% of the adrenal gland. And then the inner, which is the adrenal medulla, the inner portion, which is 10%. So mainly, you'll have disorders that mainly occur in the adrenal cortex. So when you think about the pituitary gland, let's say the pituitary gland was right here. We know that the pituitary gland, when it comes to just talking about the adrenal function, secretes ACTH in response to get the adrenal gland to secrete its three hormones, okay? So here's the adrenal, and we know the hypothalamus is up here, then the pituitary secretes ACTH. ACTH then works on the adrenal gland to make it secrete aldosterone, cortisol, and sex hormones. You have backup systems, if you look at this little diagram for aldosterone, not to be mixed up with ADH, which is angiotensin 2, and sex hormones has a backup system of the gonads. But what poor little thing does not have a backup system? Cortisol. Therefore, if something happens to ACTH production at the pituitary, let's say there's a pituitary gland infarct, and ACTH does not get secreted, the adrenal glands is not going to release these things. Well, that is horrible, but at least aldosterone has a backup plan. The sex hormones have a backup plan. So yes, the levels are going to go down, but not as much. They'll go down slightly. But look at cortisol. There's no backup plan. So if something happens, you have to replace cortisol. That is a huge, huge thing to remember. So again, as you can see, the pituitary gland secretes ACTH, effects on the adrenal glands. The adrenal glands release what I call the three S's in the presence of ACTH. Aldosterone, we said, has a backup plan of angiotensin 2. The sex hormones have a backup plan of the gonads, but poor cortisol has no backup plan. So what happens in primary Addison's, the primary organ, which is the adrenal gland, that would be the primary organ. Secondary would be something wrong with the pituitary gland. The primary, anytime you hear primary in front of something, it means something's wrong with that organ. Secondary levels at the pituitary, and tertiary is usually at the hypothalamus level. So in primary Addison's, that means something's wrong with the adrenal gland. Okay? It's dysfunctional. So it's not responding to ACTH stimulation. Therefore, no cortisol is being produced. But the other two, again, have backup systems, so their levels will either be slightly decreased or even normal. ACTH will be high. Why? Because there's no cortisol levels. So what does ACTH keep doing? The pituitary gland keeps secreting it, saying, come on, adrenal glands, I need some cortisol. Because it realizes, according to our feedback system, that the cortisol level is low. ACTH will be high because it knows the levels are low and it's trying to keep the adrenal glands, trying to get them to produce it. Remember what I say earlier. If ACTH level goes up, MSH level goes up. There's a proportional relationship. They're buddies. If you have secondary Addisons, the secondary organ, which is the pituitary gland, is dysfunctional. So it's not putting out ACTH, okay? So ACTH levels are low. MSH levels will be low as well, since, again, they're buddies. If ACTH does not stimulate the adrenal gland, no cortisol is being produced. Again, the other two have backup systems, so you may see slightly decreased levels of your aldosterone and your sex hormones. If that does not make sense, get with me. So the adrenal gland has the 3 S's, what I call the sugar, the salt, and the sex. The salt being your mineralocorticoids. That is primarily aldosterone. What does it do? It targets the kidneys. What's the purpose? To regulate sodium retention and the creation on the renal tubules. So it regulates extracellular fluid volume and blood pressure indirectly. Sugar, the glucocorticoids, mainly cortisol, targets most of the body tissues. What's the purpose? Promotes metabolism. It mobilizes body defenses during stress, and it suppresses the inflammatory reaction. So we don't want a whole lot of that on board. Sex, the androgens, estrogen and progesterone primarily, they target the ovaries and the testes. And what's their primary purpose? The development of bones, reproductive organs, and secondary sex characteristics. Okay, so what I call the 3 S's. That's the adrenal cortex. Now, the adrenal medulla has the catecholamines. Epi makes up the majority with 85 to 90%, and norepinephrine making up 10 to 15%. We know that epi targets our beta receptors, so therefore we're going to see things like increased heart rate, increased cardiac output, increased blood pressure, vasoconstriction. Norepinephrine is more of our fight or flight, and it's only responsible for 10 to 15%. And it targets alpha receptors. So it decreases blood flow to tissues that are not needed in an emergency. Now, the question is, an absence or decreased secretion by the medulla is not life-threatening. Well, I just said the medulla releases catecholamines, epi, and norepinephrine. So why would you think that if something goes on and there's an absence in the adrenal medulla that it's not life-threatening? I would figure it has a backup system. And that is absolutely correct. They are also secreted by the sympathetic nervous system and other areas when needed, but an increase can be life-threatening. So if there is a decrease, there is other things, other backup systems to help keep that level up some. So if something goes wrong with ACTH from the pituitary gland, what hormone is going to be primarily affected from the adrenal gland? Cortisol. It has no backup plan. All right, so the adrenal cortex, we can have hypo and hyperfunctions of cortisol. Hypo and hyperfunctions of cortisol. Hypofunction results in a condition known as Addison. Addison's. And why is it Addison's? The way I remember this when it comes to the adrenal cortex, these are your 2 major disorders, and they have to do with cortisol. Addison's and Cushing's. Hypofunction, I don't have enough of it. So Addison's, I need to add some. Hypofunction, I need to add some. Hyperfunction results in a condition known as Cushing's. I've got too much. I'm like a big cushion. I'm cushiony. Okay? So hint, Addison's, I need to add some. Cushing's, I got too much, got extra cushion. Okay? Hopefully that'll help you remember that a little bit. When we're looking at the types of Addison's disease, there's primary and secondary. Remember, I already talked about that a little bit. Primary is something's wrong with the adrenal gland. Secondary, something's wrong with the pituitary gland. Primary is the most common. That would be something wrong with the adrenal gland itself. Secondary, pituitary, or other causes with ACTH. Okay? And if you look in your book on page 1402 and 1403, actually 1402 has figure 46-7, which goes over how that loop works, the short feedback loops and the long feedback loops. And then on page 1407, actually goes over some of the causes under pathophysiology. You can see there on page 1407 under primary, it says gradual destruction of the adrenal cortex can result from something autoimmune, TB, decreased secretion of ACTH because of that. Whereas secondary causes on page 1407 can be anything from following surgery or damage to the pituitary. Okay. So consider, will the following hormones be up or down depending on if it's primary cause, something's wrong with the adrenals, or secondary cause, something's wrong with the pituitary. Okay. So let's think this through. All right. In primary, the glucocorticoids, that's cortisol. Glucocorticoids, the main one's cortisol. Okay. If your adrenal glands are not secreting anything, then they're going to be down, right? The mineral corticoids and the sex hormones, they are either going to be normal or slightly decreased. Normal or slightly decreased. Why is that? They have a backup system. If you remember, they have a backup system. So they're going in to see the backup system. And when you have the backup system, again, they may be either slightly decreased or normal. So your glucocorticoids, your mineral corticoids, and your sex hormones will all be decreased. But the glucocorticoids will be, cortisol will be low, where the mineral corticoids and the sex hormones will only be slightly decreased. What about ACTH? What about ACTH? Let's go back up here again, not trying to make you dizzy. But if we go back up here, if something's wrong with the adrenal gland, what is the ACTH level going to do? Well, it wants it to produce more cortisol. It knows the levels are low, so it's going to increase, trying to get this adrenal gland to do something. So if something's wrong with the adrenal gland, primary ACTH levels are going to be high. If ACTH levels are high, MSH levels are high. MSH is responsible for pigmentation. Thus, in primary, you see dark pigmented skin. Pigmented skin. Now, let's think about this on the secondary cause. Something's now wrong with the pituitary. If something's wrong with the pituitary gland, let's go back and look here. If something's wrong with the pituitary gland up here, okay, ACTH isn't going to be secreted, is it? If ACTH isn't secreted, it can't affect the adrenal glands. So again, you're going to see the cortisol level low, and you're going to see aldosterone and sex hormones either slightly low or normal. Same scenario. So just from looking at these three hormone levels, you don't know if it's primary or secondary. So how do you know the difference? ACTH secretions. Because if the pituitary gland is broke, it can't put out ACTH. So ACTH levels would be low. Therefore, MSH levels would be low. So the way that you tell the difference between primary and secondary aldosteronism is looking at the ACTH level. With the primary, ACTH levels are going to be high and MSH levels are going to be high because it's trying to get the adrenal gland to secrete cortisol. In secondary, where the pituitary gland is messed up, ACTH levels are going to be low and MSH levels are going to be low. And that's how you tell the difference between primary and secondary aldosteronism. So going back to this, will the following hormones be up or down? Down, down. Slightly down or normal, slightly down or normal, slightly down or normal, slightly down or normal. With primary, increased, increased. With secondary, decreased, decreased. And I hope that makes sense. If it doesn't, you get with me and I'll go over it again. So because of that, Addison's, we need to add some cortisol. Then one of the things we're going to see as our cardinal complaint is weakness. Weakness, fatigue, weight loss, decreased alertness, confusion, dizziness, syncopal attacks, a craving for salt, especially if your mineral corticoids are down a little bit. That's your salt. So if it's slightly down, you may be craving salt. Sodium's going to be down. Nausea, vomiting, abdominal pain, and diarrhea. Dark skin, where did that come from? ACTH level being up. Body hair changes, increase in skin pigmentation. It says dry skin. There's the increase in pigmentation, sorry. The dark skin pigmentation. Hypotension, tachycardia, hyperthermia, decreased resistance to stress because your cortisol levels are low, and a decrease in sex hormones, but just slightly. So with Addison's, here's the typical picture you would see with primary. Why is it primary? Because of the brown pigmentation of the skin, because ACTH is up, MSH will be up. The changes in the distribution of the hair, GI disturbances, weakness, weight loss, postural hypotension, and hypoglycemia results. Now you can go into what's called an adrenal crisis, and that's all of these things magnified, okay? And it almost always leads to vascular collapse if you don't correct it. All right, so diagnostic findings. If I'm going in and I'm looking at the diagnostic findings, and one of the first things that I'm going to see then would be hyponatremia. Hyponatremia, why? Well, because I have a slight decrease in the mineralocorticoids. It's not going to be a low sodium, but it will be lower. Now, if the mineralocorticoid level is normal, then I won't see the hyponatremia, okay? A decrease, I'll also see hyperkalemia because it's kind of, the sodium-potassium pump. Hypoglycemia because I've got a decrease in cortisol, and cortisol promotes, a decrease in cortisol levels promotes hypoglycemia. Okay, cortisol is one of those things that raises your blood sugar. It's a counter-regulatory hormone. So if it's low, hypoglycemia may occur. Decrease 24 urine of 17 ketosteroids. What that is, that should say keto, K-E-T-O, steroids. Sorry about the typo. Decrease 24 urine of 17 ketosteroids. What that is measuring is the metabolites of your glucosteroids and your aldosterone. So if those levels, depends on how much they're putting out, is how much the metabolites is you're going to see. So if those levels are low, you're going to have low levels. So if you did a 24-hour urine of the metabolites, you would expect it to come back decreased. Low serum cortisol levels speaks for itself. Low ACTH if secondary, high if primary. They're also going to do CAT scans and MRIs to check for tumors and other things. So this, I believe, calls for a stimulation test because I have a low level of something. So what are they going to stimulate with? Well, they're going to go in and they're going to give ACTH, okay? ACTH, and levels will not rise during the test. So because I can sit there and stimulate all day long that adrenal gland, but if it doesn't matter, if there's something wrong with the adrenal gland, then cortisol levels are not going to increase. Now, if this is because of a secondary cause, something's wrong with the pituitary, and I give ACTH and the levels rise, then I know something was wrong at the pituitary level. So a stimulation test is going to tell me if this is also a primary or secondary. Because if I give ACTH and cortisol levels rise, then I know something's wrong with the pituitary and it's not putting out ACTH. If I give ACTH and the levels the ACTH levels continue to rise, but cortisol levels don't rise, I know something's wrong with the adrenal gland itself and it's not putting out. So what is management going to be? Decrease your stress, IV therapy, replacement therapy with cortisol, and it's going to be lifelong. You cannot go without it. We have to have cortisol, guys. So, this is in several different forms. You can get hydrocortisone, cortisone, methylprednisone, dexamethasone. You can see here there is a pattern. The pattern is there ending in the word one, O-N-E. So just a hint for boards, if you're not sure of a drug and it ends in the word one, O-N-E, think steroids. Think steroids. So what kind of teaching are we going to have to do? Well, they're going to have to know during stressful times, because we know what stress does. It should increase the cortisol level. Well, if they don't have it on board to increase during the cortisol level, then we've got to help them. Okay, so you always increase the cortisol levels during stressful times. What's the worst that can happen? The worst that can happen is you go into a temporary cushion syndrome, which is much better than the alternative, which is death if you don't do something. Okay? Now, the Florinef up here, the Florinef or fluorocortisone, is aldosterone. And that's what we give if the aldosterone level is low. Sometimes it's not, and we don't have to give that one. But if the aldosterone level is low, we give the Florinef. Otherwise, we always have to give some source of cortisol because there is no backup plan. Okay? So again, if in doubt, take extra cortisol. If in doubt, take extra cortisol. Low levels can lead to death, but high levels can lead to Cushing's. Which would you rather have? Okay? And which would you rather your patient have? The dose may actually even have to be tripled during stress. Oh, no. Yes. Oh, yes. Think about it. If you give too much, again, I'd rather be cushiony for a little bit. So teach them not to miss doses, not to stop their medications abruptly on their own. It's very important they take this for life every day. They need to try to decrease their stress as much as possible. So if they come into the hospital and they're in an Addisonian crisis, you want to decrease their stress as much as possible. Putting them in a private room to limit disturbances, keeping that temperature down, noise levels down, promoting physical and mental rest. You want to do everything that you can to help with that. Nursing considerations. You're going to monitor hydration status, oral and liberal intake of salt if the mineralocorticoids are low. Teaching stress management. They always need to be wearing a medical alert bracelet. You need to be teaching them about medications and avoiding infections. And always tell them to be watching for signs and symptoms of the Addisonian crisis, because I said earlier that can lead to vascular collapse if not treated and corrected. So, management of Addisonian crisis, treat the cause. What's the cause? Low cortisol levels. They need more cortisol. Their levels are extremely low. So, the three main goals, if someone's in an Addisonian crisis, you need to add some. You're going to have to reverse the shock, restore blood circulation, and replenish essential steroids. If you do that, the crisis will usually pass in 12 to 24 hours if treated. Okay. Now, we do have some non-compliant patients out there that just don't like to take medicines every day. So they can go in and get cortisol acetate pellets. And those pellets are sub-Q. And they put them under their skin, and they release cortisol, and you have to go in and have those pellets replaced about every 9 to 12 months. So if you do have someone who keeps coming in with Addisonian crisis, not taking their cortisol, just know that there are cortisol acetate pellets out there that can be given sub-Q that would help with that. Okay? So hopefully that made sense. Because if you get this one, you get the other one, because it's just the opposite. Okay? So let's look at Cushing's. Okay? Let's look at Cushing's. Cushing's syndrome is given when you have excessive cortisol, and this is hypersecretion of cortisol. Now, you rarely see this in children, and mainly when you think about cortisol, there's the good, the bad, and the ugly of cortisol. Okay? The good of cortisol is, these drugs help control and reduce inflammatory response. They can suppress the immune system some. The bad is, although there's a slow internal and external deterioration of the body, the trade-off is that the steroid is chronic or autoimmune disorder will usually keep you alive longer than if the inflammatory process was left unchecked. And then the ugly is that, it can cause edema, it can cause ulcers, delayed wound healing, infections, osteoporosis, high blood sugars. So, in other words, what I'm trying to say is they're not without a trade-off. That's all I'm trying to say. Okay? If you see someone who's on cortisol therapy for a long time, you think of that moon face shape. You think of fat being deposited in areas that it shouldn't be. And when they come off the drug, usually their body fat will change back to normal over time, unless they develop what's called Cushing's syndrome, where they're constantly putting out too much cortisol. Okay? The causes for Cushing's, and sometimes you'll see it called Cushing's disease, is iatrogenic, too much cortisol. Okay? That one we can deal with pretty much. We just taper them off and they go back. Primary means something's wrong, again, with the adrenal gland. So usually it's a tumor and it's over-secreting cortisol so that we have too much. Secondary would be something wrong with the pituitary gland, and usually, again, it's a tumor. It's secreting too much ACT, therefore it's putting out too much cortisol. Manifestations, you're going to see the normal function of the 3 S's are exaggerated. The normal function of the 3 S's are exaggerated. If you look on page 1410 in your book, there it talks about some of the nursing management and adrenal hyperfunction of a Cushing's syndrome. You can see there the patient with Cushing's syndrome, and it shows you a figure 46-10 of what atypical signs and symptoms would look like. So you can see there's weight gain, particularly in the abdominal area, moon face, what we call the buffalo hump on the back, thin extremities, protein tissue wasting and weakness occurs, loss of skeletal calcium, so they get fractures, frequent infections, so you can see down there poor wound healing, mood swings. If it's a pituitary tumor, they can also have some vision issues. Hirschism, or increased hair growth, they may actually result in that, in male-like masculine features. Hypertension, edema, congestive heart failure can result. They bruise real easy. They get a lot of that because of the lack of collagen support of the blood vessels. They get pale purplish striata. That's very common from thinning of the skin. And hyperglycemia from too much cortisol instead of hypo. So if you look at these diagnostic findings, they are just the opposite of add some. So if you get one down, you get the other one down. So now I have hypokalemia instead of hyperkalemia. I have hyperglycemia instead of hypoglycemia. I have hypernatremia instead of hyponatremia. Because remember, if I've got too much ACTH and it keeps pushing that and pushing that adrenal gland to secrete, I'm also getting extra mineralocorticoids and extra sex corticoids. That's why I get the Hirschism and the Vertilism, because of the increase in the sex hormones, and that's why I get the increase in the sodium and the hypertension, edema, and CHF, because I'm putting out too much salt. Elevated 24 urine ketone steroids instead of decreased. Now they're elevated because I've got extra metabolites in the urine. And a high serum cortisol level. So it's just the opposite. Testing. Now I need to do a suppression test instead of stimulation test because I've got too much. So the suppression test, what they're going to go in and do overnight is do a dexamethasone suppression test. So remember, cortisol follows a diurnal pattern, rises early in the morning and it falls in the evening. And we know stress is going to affect that. So we want that environment to be as stress-free as possible when we are getting ready to do our test. Okay? So what they're going to go in and do is do that suppression test. If they give more cortisol, that should suppress that from releasing more. But what will happen is it will continue to do it if something's wrong. So management, if it's pituitary tumor, then surgery and radiation. If it's an adrenal tumor, then surgery and replacement therapy. Okay. Pharmacological treatment can suppress or block the synthesis of cortisol and ACTH, depending on where your problem's at. But they may have to do an adrenalectomy. And if they do that, remove the adrenal gland, you're going to have pre- and post-op teaching. For pre-op teaching, we're going to have supportive care, correction of any fluid and electrolyte imbalances, and of course you want to decrease stress as much as possible. If this is a child, of course, appropriate communication techniques. Make sure you know how your patient learns the best and that you teach that way. Post-operatively, you need to remember these medications, and they are going to have to know they're going to have cortisol for life if they remove the adrenal gland, and they may have to have other issues as well, because remember, the adrenal glands don't just support cortisol. So if their mineralocorticoids go down, they may need that Florinaf. If their sex hormones are down, they may need those replacements. So it just depends on how bad it affects it, because those two do have backup plans. They're going to be in ICU on INO and daily weight. You're going to monitor their lab, control their pain, turn, cough, and deep breathe, and decrease stressors as much as possible. So, just a critical thinking question. What type of diet would you serve a patient on Addison's? Well, I think we would have to look at the lab findings. What type of diet would you serve a patient on Cushing's? Again, look at the lab findings. Let's take Cushing's, for example. We know they're hyperkalemia, so increase the potassium. We know they're hyperglycemic, so decrease the bad carbs. We know they're hypernatremic, so decrease the sodium. So think about that when you're making diet choices on the exam. Okay, look at their labs. They are complete opposite. If you get one down, the other one's opposite. I would write these down on a piece of paper before the exam started so that I didn't get them confused. Cushing's syndrome. Here's our Cushing's syndrome. Again, there's the signs and symptoms, and it's very similar to what's on your book on page 14 and 10. Okay? All right. What about CAH, congenital adrenal hyperplasia? This is an autosomal recessive disorder that's in your PEDS book on page 990. What is it? Well, it's caused by an inborn deficiency of one of the enzymes needed to synthesize cortisol and aldosterone. In CAH, there's an inadequate blood level of cortisol. As a result, there's an increased secretion of ACTH by the pituitary saying, I need more, I need more. Well, after a while, prolonged hypersecretion results in gland hyperplasia. So now not only do I have an increase in cortisol, I have an increase in the salts, and I also have an increase in the sex hormones. Now again, you got to remember, this is happening, it's an inborn deficiency of one of the enzymes that's needed to synthesize cortisol and aldosterone. But I had to replace those, but don't forget ACTH gets hammering and hammering and hammering at that adrenal gland, and I still have the sex hormones who are doing fine over here, but because ACTH keeps on, I have an increase in those sex hormones, okay? What it results in is the androgen causing ambiguous genitalia in females and precocious genitalia in the males. It is much more pronounced in the girls, okay? So in females, you're going to see things like an enlarged clitoris, fusion of the labia, closed vaginal orifice. It almost looks like a small penis, and you can't tell sometimes at birth if it is a male or a female at that point. So unfortunately, some children do get misdiagnosed. They think they're males and find out later that it was a female. Males have genital enlargement, frequent erections, early secondary sex characteristics, okay? And they have difficulty assigning, again, a sex to the newborn. They don't have as much difficulty with the males, but they do with the females, okay? Management is usually to confirm the diagnosis and assign a sex to the newborns. This is lifelong replacement because of deficiencies in the mineralocorticoids and the corticosteroids. They do have to wear medical bracelets, and once they fix the mineralocorticoids and the steroid corticoids, then they don't have as much problems. Nursing considerations is to identify the child and using the right words. You know, you have a beautiful baby, you can say things like that. Use neutral names until they figure out what the sex is. As far as management, again, they want to confirm the diagnosis and assign a sex to the child as early as possible. And then again, replacement with the deficient hormones and medical alert bracelets. They will need glucocorticoids to suppress ACTH secretions, so they will be getting those. In females, they're going to have reconstructive surgery, and that's usually successful. They go in and do labia separation to create a vaginal orifice, and then vaginal dilatation over the years. Most agree that surgery should be before the child's old enough to realize something's wrong by 1 year of age. And most experts say that it's better to wait until, some experts do say that it's better to wait until adolescence so they can participate in the decision making. But most experts say that's too long. By then you're trying to figure out who you are anyways, so that is up for debate. But most surgeons do agree it's better to do it by about 1 year of age. Okay. All right. Disorders of the adrenal medulla. These are quite rare, but death can occur without intervention because of the increase in blood pressure. This is most common in our 40 to 60-year-olds. Okay, but without early intervention, cerebral hemorrhage and death will occur. Pheochromocytoma is the most common, and this is a neoplasm that produces excessive catecholamines. Now, catecholamines was our epinephrine and our norepinephrine. And if you remember back, go back and look at what they do. They work on the beta and the alpha cells. So think about all those things being magnified. The main cause, a tumor, because here we are having a hypersecretion. It can be on the gland, it can be in the abdomen, it can be in the pelvis, it can be in the thorax, it can be all over the place. Manifestations, hypertension, and the classic triad. The classic triad is severe pounding headache, tachycardia, and profuse sweating, because all of those things of epi and norepinephrine are speeded up. So why would you monitor blood sugar levels? Because if you'll remember, epinephrine, norepinephrine are counter-regulatory hormones, so they also cause hyperglycemia when they are at high rates. Okay. This is very rare in children. Mostly you will see this again in adults. In adults, blood pressure readings have been recorded as high as 350 over 200. I absolutely do not know how people have not stroked out over that. In children, on rare occasions that it occurs, it's been as high as 250 systolic. Pressure is so high because of the stimulation of the alpha and beta receptors. Okay. Diagnostically, we're going to do an H&P. We're going to find increased plasma levels, increased urine levels, and the urine test that we're going to do is VMA and metapines, which is the measure of metabolites of epinephrine and norepinephrine. And with the VMA and the metapines, you will have increased levels in the urine. The CAT scans and MRIs are done to rule out tumors. And of course, we have too much, so we're going to do a suppression test. And they're going to do that with catapress. Catapress will usually decrease the epi and norepinephrine and those signs and symptoms, but in this case, it will not work if it's positive. It will keep on stimulating it. Management, if the mass is present, do not palpate. Do not palpate. They're put on adrenergic blockers. Treatment is surgical removal. You will always want to make sure that you avoid stimulants. Avoid any kind of stimulants. Avoid stimulants. Avoid certain tyramine in cheese and wines because that affects it as well. It makes it increase. There is medications that can help with it some. They are enzyme inhibitors that inhibit the initial step in synthesis of catecholamines. So if it inhibits the catecholamine production, then that will help. And that works in about 80% reduction. So that medications do help. This is one of the few conditions where it's dangerously high blood pressure can be controlled by surgery. Now, pre- and post-op teaching needs to occur. Preoperatively, they need to know about their medications, the correction of hypervolemia, and any kind of cardiovascular complications. You want to make sure they're stable before surgery. They're going to be put on alpha adrenergic blockers to prevent hypertensive crisis during surgery for about 15 days prior to surgery, because they want that blood pressure down as much as they can before surgery, because once they take that out, some of that can spill over as well and cause dangerously high blood pressure for a little bit. Post-operatively, monitor blood pressure carefully and blood sugar. Replace the therapy as needed. Teaching that this can reoccur, unfortunately, and sometimes pheochromocytomas do come back. They need to make sure that they're doing follow-up care and that they can resume normal activity within about a week. Okay, the last stop, one more adventure on our way, will be the thyroid and parathyroids. Thank you.